welcome to the AIOC midterm. Pleasure to be starting this first session, ophthalmology free paper session. I am Dr. Rohit Saxena, the chairperson of this session. I have with me Dr. Jayanta Kumar Das, my co-chairperson. Convener is Dr. Niba Anand. I saw her. She must be finishing her lunch and she'll be here. Dr. Ambasti Anita is my co-convener, and Dr. Tanmay Biswas is the moderator. So, Tanmay, why are you sitting there as if you are supposed to present? Huh? Here, please keep this. You need to mark. I hope you remember that. So, thank you. We'll just, I'll read out the first four next presenters so that we know the others are ready. And then we'll keep announcing as they go. So the first paper will be Dr. Jay Gopal Agarwal. He's here. You can come. We'll just start in a minute while announcing. Just please check that your presentation is there. The next speaker is Dr. Pranay Kumar. He'll be followed by Dr. Prasanna Venkatesh Ramesh. I saw he was here. And Dr. Saranya is the fourth speaker. Dr. Saranya here. Great. So first four are in place. I think we'll start. So thank you, everybody. So we will only be marking the ratified members because only the ratified members can get the award. The rest, of course, get the opportunity to present, but unfortunately we will not be able to mark them for award. Yeah. Dr. Ashwini, sorry? Sequence while they are still struggling with the AV, I'll speak out. So fifth is Dr. Shafina P. Sixth is Dr. Kiran Bhanot. Seventh is Dr. Kiran Sarode. And seventh is Dr. Namrata Shri, followed by Dr. Aditya Anand, and finally Dr. Shamda Iqbal. I'm not sure if I have the names which you asked me to. Are you sure in the Neuro Ophthalmology presentation? So that I don't think is right now. Maybe that is subsequent. Yeah, that's after this. So that is the next session. Yeah, that is the next session. So please remember the time allotted, because there will be negative marks for overshooting. We have marks for on all these four, and as I said, they should be within time because overshooting will be negative marks. So all the best, everybody. Time is 5 minutes. Time is 5 minutes, yes. एक बार timer आप लगा दीजिए so that everybody knows.
Respected chairpersons, my topic is to start high dose of IV methylprednisolone for aquaporin 4 or MOG optic neuritis is the present dictum for visual recovery and outcome in optic neuritis patients. In other words, wasting time to start high dose of IV methylprednisolone for aquaporin 4 and MOG optic neuritis is a blunder for visual recovery and outcome. There is no financial interest. As per North American optic neuritis treatment trial, the acute treatment of optic neuritis in multiple sclerosis by IV methylprednisolone accelerates the recovery but do not affect the final visual outcome, thus showing the sense of non-urgency of the treatment in acute phase of optic neuritis. But new era of biomarkers such as aquaporin 4 and MOG positive patients, watershed line starts. The clinical course of optic neuritis differs from multiple sclerosis, typically steroid responsive, very much steroid dependent, associated with very poor visual recovery and outcome, and poor recovery from each attack of increased accumulated disability. The purpose is to find the role of high-V methylprednisolone, whether the earliest treatment, that is urgency, that is minimum time from the onset of symptoms to IV methyl prednisolone, it results in the best corrective visual acuity recovery after the 3 months. The diagnosis of optic neuritis is based on the clinical history. Objective finding as determined by the clinical examination of the neuro ophthalmologist and the paraclinical tests. All diagnosed cases of optic neuritis have to have the diagnosis of aquaporin 4 and MOG associated optic neuritis based on the established diagnostic criteria, that is International Consensus of Diagnostic Criteria of NMOSD in 2015. And it is examined by the commercial cell-based assay. On the basis of our methodology, a retrospective study was performed. Total number of cases is 38, among which 30 are the aquaporin 4 positive and the 8 are the MOG positive. The study is focused on the visual acuity as a functional outcome, not other functional parameters such as visual field and structural anatomy outcome that is as defined in the OCT. Documentation is done for the age of the patient, sex, antibody groups, time to start the IV methyl prednisolone, and best corrective vision at the time of reporting, and the best corrective vision at 1 month and 3 months. At the time of presentation, even if the study antibody status is not known, urgent IV methyl prednisolone for daily dose of 1000 milligram for 3 to 5 days, followed by the oral prednisolone starting at the 1 milligram per kg body weight per day for 11 days and then taper off in the next 21 days. The main outcome measure are 3 month best corrected visual acuity and the failure to regain 20 by 20 or the vision or the vision at 3 months following visual follow-up. This is the data of my study. This broad plots diagram shows the distribution of best corrected visual acuity 1 month for the patient treated with aquaporin 4 and the MOG positive eye. And the best corrected vision 1 month in the patient treated with less than 7 days is better than the patient treated more than 7 days. This is the same thing, here the best corrected visual acuity is calculated at 3 months. Here again the best corrected visual is 3 months the patient treated within the 7 days is better than the patient treated after the 7 days. This is the ROC curve analysis, so failure of regain 6 by 6 as a dependent variable. And the predictors are the cutoff time for IV methylprednisolone, age of the patient, and best corrected visual acuity. When the cutoff time to IV methylprednisolone as counted individually, then it is the AROC curve. The area under the curve is 8.8. And if you consider the age and best corrected visual acuity at start, then the area under the curve is very low. And so the cutoff time for IV methylprednisolone is important. So here the Yodon's optimum criteria is the best corrected visual acuity comes when it is treated less than 4 days. When it is the same thing, but where it is the curve analysis for this is 20 by 30. Here again it is said that find that the ROC, the failure to regain vision, if the treatment is within 7 days, is better than if criteria is correct the age of the patient and best corrected visual acuity at the start. Next is the in our study, the patient with the aquaporin 4 and MOG positive optic neuritis respond better if earlier treatment is started. So if pathology genesis is considered, then irreversible axon damage is starts with the within 5 to 7 days. So supporting our clinical finding with the optimal treatment should be start with less than 4 days, but the treatment before 7 days still offers opportunity for very good visual outcome. So the time is the tissue. It is a core principle that is evolved in the field of neuro ophthalmology. So start the treatment just as soon as we can, but better it is less than 4 days. Thank you.
Excellent one, excellent good study. What is your aim of this? Why you want to present this one?
Why?
Is it almost
Because
established
earlier
factor?
it is said that in the multiple sclerosis cases, or as I have shown you, that the treatment.
Could you speak in the mic, Dr.
Yes.
Yeah.
they show that if you start the treatment with IV methylprednisolone, it's a non-urgency because recovery is good, but again it comes to the in the same position. So the recovery is so after recovery it again back to the previous position. So in that cases, so we cannot find, it is not a it is a non-urgency, but after the aquaporin 4 and MOG positive antibody diagnosis, those cases, if treated urgently and in the high dose of methylprednisolone, if it is within 4 days, the excellent result we can get, even if it is that the crush is that we should start the treatment as early as possible, because at that time, within 4 days, it is not possible to get the MOG positive or aquaporin 4 result. So it is better to start as early as possible. Here it is an urgency.
Dr. Agarwal, what was your total N size? All those whom you tested but were negative for MOG, NMO MOG?
MOG.
How many were, no, the reason why I'm asking you this is that you can only show relative advantage
Yes.
in NMO MOG
Yes.
of early intervention if we compare it with the group that was
Yes.
optic neuritis but negative for
Yes,
NMO
yes.
MOG. So
Yes.
do you have the data of the
Yes, yes,
non-NMO MOG patients, and can you so compare it with them and give comparative outcomes would give us much.
If you just if you can just go for the diagnosis with aquaporin 4 and MOG is very less. Aquaporin 4 is you can find in the better number of cases. But the overall is that only the 20 to 30% cases we get the either MOG positive or aquaporin 4.
True. So you have the data of the negative NMO MOG to compare with the current data?
Actually, we go for the all tests you test, but it is find that the only 2 to 3% MOG positive are presented.
Sure. Okay. Any questions, Tanmay? Yeah.
Did you sort of say which type of optic neuritis you'd like to start IVMP even before you got the MOG and the aquaporin, because that is going
Yes.
to take time?
Yes.
Or did you give the IVMP to all the optic neuritis patients that you saw?
No,
or was
it
there
is
any criteria
but
for
it-
which kind
but
of?
yes, it is that we should at least go for we examine after the clinical examination. If it is optic neuritis, pure optic neuritis, then there is no problem. But whether it is infective, and in other situations where the steroid is not contraindicated, we cannot go for that immediately. Wait for some time. If I get the aquaporin 4 and MOG positive, then we can start with the treatment. But in those cases that is infective, where we should not get problem.
Thank you.
Thank you.
Next speaker is Pranay Kumar, please. Okay.
Good afternoon, everyone. My topic is an OCT-based study of retinal nerve fiber layer changes in migraine. No financial interest involved. Migraine refers to a primary headache disorder commonly characterized by severe unilateral throbbing pain and may be associated with nausea, photophobia, phonophobia, and or preceding aura. The prevalence of the disease is somewhere between 2.6% and 21.7%. Women are affected more than men by almost 35%. Migraine is a transient phenomenon of cerebral vasoconstriction. The long-standing cases of migraine may lead to retinal structural abnormalities. The chronic migraine causes anomalies in microcirculation of optic nerve head and may cause retinal hypoperfusion. The retinal hyperperfusion finally leads to ganglion cell death in such patients. Aim of our study was to compare RNFL thickness between migraine patients and healthy controls and to assess the quadrant which is most affected by migraine. It was an observational case control study conducted in which we took 96 migraine cases and 96 healthy controls. Inclusion criteria included both male and female patients in the age group of 20 to 60 years who were diagnosed as migraine. Patients with glaucoma, high myopia, diabetic retinopathy, hypertensive retinopathy, retinal vascular occlusive disorders, and any other neuro ophthalmic disorders were excluded from the study. Every cases and controls underwent local ocular examination that included best corrected visual acuity, color vision, Goldman measured IOP, retinal examination, fundus examination. Finally, OCT of the optic nerve head was performed to evaluate the average RNFL thickness and symmetry of both the eyes, in addition to the RNFL superior, nasal, temporal, and inferior quadrant thickness. Results. In our study, the mean age group of the cases was 39 years plus minus 10.3 standard deviation, and that of the control group was 41 years plus minus 9.2 standard deviation. Out of the 96 migraine patients selected for study, 65 were female and 31 were males. RNFL thickness amongst cases and controls, the thinning was significantly more in cases. Out of 96 cases, 62 had RNFL thinning, the average value being 87 plus minus 9.2 micrometer. On comparing with controls, there was statistical significant difference with p-value less than 0.05. Maximum cases which had RMFL thinning were women. Out of the 62 patients which had RMFL thinning, 44 were women and 18 were men. On comparing with controls, there was no statistical difference. Maximum cases which had RMFL thinning belonged to the age group of 30 to 40 years. The mean age of the study sample was 39 plus minus 10.3 years. On comparing with controls, there was no statistical significant difference. Maximum number of cases had temporal quadrant thinning, value being 53 plus minus 10.1 micrometer. This was followed by nasal quadrant thinning, the value being 74 plus minus 11.6 micrometer. On comparing with controls, there was significant difference only in the temporal quadrant thickness with p-value less than 0.05. This is the data collected, and we can see only the average RNFL thickness and the temporal quadrant thickness showing significant values. The mean age of migraine patients in our study was 39 plus minus 10.3 years. This was fairly consistent with the study of Leslie-Kellman, in which the mean age of migraine was 37.7 plus minus 11.7. In our study, the average RNFL thickness was 87.8 plus minus 9.2, which was significantly thinner when compared to healthy controls. The result of our study corresponded with the results of Elizabeth Khosravi, which showed that RNFL thickness was significantly thinner in migraine patients when compared to the control group. In our study, the mean temporal quadrant thickness was 63 plus minus 10.1, which was found to be thinner when compared to controls. In the study of Martinez et al. Using OCT, he found that the RNFL was significantly thinner in the temporal region in migraine patients when compared with age-matched healthy subjects. Abnormal RNFL thickness has been observed in patients of Alzheimer's disease. So, RNFL thickness can be considered as a potential biomarker for Alzheimer's. RNFL thinning is associated with cingulated cortex atrophy and episodic memory decline in old age. So, it can be used as a complementary index of neurocognitive degeneration. The thinning of RNFL is also associated with patients of multiple sclerosis. As we all know that multiple sclerosis is a central nervous system disease with optic neuritis being a manifestation. So, it can be considered as a biomarker of neuroaxonal damage in such patients. The limitation of this study was that we did not assess the ONH parameters and RNFL thickness based on the severity of the disease using the MIDAS score. The migraine disability assessment score is a well-known tool to assess the severity of migraine. Conclusion. Migraine is a common problem. It is the second most common cause of headache affecting women primarily. There seems to be a strong correlation between average RNFL thickness and migraine, with RNFL in temporal quadrant being significantly thinner in migraine patients. OCT has recognized a new pathway for anticipating neurological disorders such as Alzheimer's and multiple sclerosis. Though this remains a question that whether OCT can be used as a screening tool for diagnosis of neurological disorders. Several studies need to be performed. A much more defined study including parameters such as choroidal thickness and ocular perfusion pressure will certainly yield better results. Thank you.
Thank you. How did you come to the sample size of 96?
Sir, this is according to our OPD patients. Sir.
But you could have calculated. I mean, it's a
Sir,
good sample size.
sir,
I'm not questioning that.
Oh, no.
It is just that it was a little unusual
No,
that
no,
you come to 96, and I didn't see a sample size calculation to estimate that. But I'm sure if you use your, as you have compared a previous study, I'm sure if you do that,
Yes,
it will just add strength to the study and the presentation that you're making. Although it's not right to make a sample size estimation after the surgery, after your study.
What are your exclusion criteria? So it is a migraine is a basically it's a meaning is a disease of exclusion.
Yeah.
What are your assessment protocol to exclude others?
Sir, migraine is basically a diagnosis of exclusion.
Yes.
Yes, sir. So, pardon, sir, I didn't get you.
So how did you exclude other pathological conditions? How did you come to that this is the only cause or the effect on the OCT that you are observing?
Sir, and sir, when we come to our exclusion criteria, sir,
I think what Dr. Saxena is trying to ask you, how was the diagnosis of migraine made?
oh, sir, that was from medicine department, sir.
Not by you.
No, not my, yes, sir. So, patients with medicine department who were
Medicine
diagnosed as patients.
department on what basis, on what background you
Sir,
are
sir,
evaluating.
I will clarify totally. Sir, patients came in our OPD. They were shuffling between medicine department and ophthalmology department. They went towards their refractive error. After correcting also refractive error, they complained of headache. So the medicine department guys diagnosed as migraine. So we took them as such patients.
Yes, it's actually basically in our practice the over-diagnosis of migraine. There's a lots of other, even simple hypertension, sinusitis, so many issues are there
Yes,
in
sir.
OPDs in reality.
I agree,
And
sir.
everyone tell is a migraine. Actually not. There may be some even, as a ophthalmologist, we are also a MBBS student. We can examine in our by direct also ophthalmoscopy, is there in a DNS?
Yes.
Tenderness on the sinusitis, and the one is important is labile hypertension.
Never.
Those are initially missed by lots of the doctors. Yes. Oh, yeah. Please invite. Please invite. Okay. Our next speaker is Dr. Prasanna. Prasanna, yes.
Yes, sir. No, sir. Thank you, sir, for the opportunity. Can I start, sir? Yeah. Yeah. Can I start? Can I start? Okay. Mine is it's an app on Neuro Ophthalmology. Mine is an app on Neuro Ophthalmology for teaching as well as for counseling. How we have used a 3D interface and evaluated this app actually. So the problem was actually there was a lot of theoretical framework which was actually going and limiting our cognitive way of understanding neuroophthalm. For example, when we see a particular structure, there are so many illustrations. We need to have a lot of cognitive way of understanding things. And there was no app as such which used a 2D or 3D animated data set to build a real interface one. So we went ahead and you can see here, not only did we build one with 3D augmented reality, we also made use of subtractive learning. So the structures that you don't want to see, you can actually subtract it and use your finger in the iPhone. In anybody's phone today, you can actually download this at the end in the QR code free of cost. And this is a virtual dissection that can really be done. Now there is no blind spot as such and there is no need to mug up because you can actually with the help of your fingers on the right hand side, you can rotate it and have any view of choice that you want to see. And not only that, even simple examinations like a simulator of the fundus as on the left hand side can go in by taking your phone into the pupil, and all this actually gave a good hand-eye coordination. So we made sure we did the complex neuro-ophthalmic structures along with the ophthalmological structures and evaluated this. The purpose was what was the satisfaction level and the scoring level for a neophyte, a first year postgraduate, using this app and without this the conventional method. A cross-sectional study, a comparative study on a Google platform using these features of 3D features, questionnaires pertaining to knowledge and comprehension, the graphics and gamification, was it really good, the tutorials, the innovative representation and the additive features. So 217 people actually downloaded this app, so we did send them and 203 responded. So those were the included people. And the feedback was out as to what did they feel. It was more of a self-reported one. That was a limitation actually. But what was the satisfaction level with this and without that? Was it satisfied or were they neutral or were they not satisfied? And these discrete variables were converted into continuous variables and a pair t-test was used and it was actually significant. It was not that bad. With the app, they told it was 97.4% satisfaction levels. Without this also it was 89, but there was a slight elevation of the three-dimensional representation, especially when they have used this particular technology, because there was no blind spot as the anatomy was not mugged up or not cognitively memorized. It was more practical and a smooth flow. So this is more like a pedagogical transformation in neuro-ophthalmic learning where there is no more two-dimensional representation, and it can also be used in e-counseling stations, and not only neuro-ophthalmology, even in ophthalmology, as any simple procedure to a complex surgery can actually be done. So this is the QR code of this app, my dear friends. It's on the Apple Store. By scanning this, you can actually get this app today. So according to our knowledge, there is no app till date which incorporates real-time, high-resolution, real images, the real images of the fundus, the real gonioscopic structures, or even currently we are working on incorporating the CT and the MRI scans for neuro-ophthalm with a filter, with photoreal visuals, and it simplifies neuro-ophthalmic concept learning for an immersive 3D pedagogy as well as for patient counseling. It is available today. Scan the QR code and you'll get it. Do use it and see. And thank you, sir. Thank you for the opportunity once again.
Thank you, Prasanna. It's something that we must need. I mean, there should be some glamour in neuro-ophthalmology also.
The purpose was, I was not able to understand when I read, sir. I was taking long time to read. I was mugging up the circle of Willis by drawing a pentagon or a hexagon, then an horizontal line, then 2 lines for the basilar artery. So the idea was, I never knew how the angulations were going and inserting with each other. So why not we give it in 3D? The main issue with creating this was we had to go back and read the anatomy with every angulations and everything. The model construction was taking a long time, but then everything set into place. So now with the iPhone, this QR code will actually give you this app.
New concept. Okay. Any question? Yeah. Yeah.
It's a very nice presentation. I wish there was some kind of a video, for
Yes, ma'am.
your presentation.
Yes, ma'am.
Maybe the time was too short, 5 minutes.
Yeah, 3 minutes only is it.
Yeah.
It was more like a JPEG, not a video, more of transitions.
Maybe I'll go through it then.
Thank you, thank you. Thank you, ma'am.
Our next speaker is Dr. Saraina.
Good afternoon.
No, yeah,
Good afternoon. Good afternoon, everyone. My paper is on decrypting the mystery of bilateral unreactive pupils. There is no financial interest in this case study. Adie's pupil is an efferent pupillary defect in which there is parasympathetic denervation of the afflicted pupil. It is usually an unilateral condition common in young female with underlying local and systemic factors. The occurrence of isolated bilateral simultaneous Adie's tonic pupil in a 14-year-old male need a detailed workup. This is a case report of 14-year-old male came to OPD with complaints of difficulty in seeing bright light for past 1 year. History of difficulty in reading was present. No history of redness or watering of eyes, headache, fever, no history of drug usage, no history of any systemic illness or autoimmune disorders, no history of ocular trauma or surgery. On ophthalmic examination, his vision was improving to 6/6 in both eyes, but near vision, he had near vision defect, which was corrected with plus 0.5 D sphere. Other anterior segment examinations were normal, but pupil was 5 mm. Both eye pupil was not reacting to light, both direct and indirect, in bright and dim light, and accommodation reflex was absent. His near point of accommodation was 14 centimeter, near point of convergence was 9 centimeter. Fundus, color vision, contrast sensitivity, fields and extraocular movements were normal. On systemic examination, deep tendon reflexes were elicited and were normal, and systemic examination of CVS, RS, CNS, everything was normal, and blood pressure was 120/80 within normal limits. On digging into diagnosis, the denervation supersensitivity test was undertaken. The patient underwent dilute pilocarpine test of 0.125% in dim light room. Pupillary right reflex was recorded at baseline and at 30 minutes after instilling the drops. Here, this is a video of the non-reacting pupil. This is a video of non-reacting pupil, and after installation of pilocarpine in dim light, the pupil constricted and it reacted. This is the picture before pilocarpine test and after pilocarpine test, which the pupil constricted and reacted to light. Pre-drug and post-drug effect. Deviation was N8, pre-drug, and post-drug it was N6, and near point of accommodation reduced from 14 to 10, and near point of conversion from 9 to 7 centimeter. Light reflex, direct and indirect was absent, and near reflex was also absent, and 0.1% pilocarpine test was positive. This made a diagnostic dilemma, and it's a diagnosis of exclusion. It came up to Adie's tonic pupil, ruling out Ergel-Robertson pupil as accommodation reflex is absent. Pharmacological mydriasis as iris is normal. There is no history of use of any mydriatics, and pilocarpine test was positive. And traumatic mydriasis, since the iris was normal and anterior segment structures were normal. Third, cranial nerve palsy was ruled out since ocular movements were full, and congenital mydriasis was ruled out since pilocarpine test was positive. On treatment and follow-up, the patient has been advised to do a detailed neurological examination and serological workup to rule out any associated diseases. MRI brain showed no significant abnormality. Neurology and cardiology examination was found to be normal. Serological examination does not show any abnormality. Best glasses for the near vision has been prescribed. On discussion, mydriasis is often an worrying sign. Neurological causes to be ruled out by neuroimaging. Ocular and systemic abnormalities also have to be investigated and evaluated. Here we present a rare case of isolated simultaneous bilateral Adie's pupil in a young male. Our patient did not have any associated ocular or systemic pathology. However, intracranial cause was ruled out using neuroimaging, emphasizing its importance. Adie's tonic pupil is a disorder of unknown etiology in which there is an injury to postganglionic parasympathetic nerves resulting in poor light. This is a flow chart of how we did the diluted pilocarpine test, for which large pupil constricted and suggested supersensitivity in Adie's tonic pupil. Thank you.
Thank you.
Did you check for any reflexes?
Ma'am?
Did you check for any reflexes? Did she have any neurological workup?
Yeah, he did he's a male patient, he did every neurological workup. It turned to be negative. Everything was normal. Sir, for bilateral Adie's pupil, since the pupil is not reacting, we suspected some neurological pathologies like dorsal brainstem disorders. Like that we suspected and advised for MRI. And dorsal midbrain symptoms. No, sir. Pupil will not react to light.
Okay, fine.
Thank you, sir.
Call the next one. Next.
Yeah, Dr. Veerna, Dr. Shafina, please come in. Dr. Shafina P. Please come up with a presentation. Okay, then Dr. Minakshi Shiokand.
Good afternoon, everyone. I'm presenting a very intriguing case of pseudo papilledema case report. There are no financial disclosures for this presentation. First, a brief introduction. Optic disc edema refers to the swelling of nerve fiber layer at the optic nerve head, and it's always because of some etiology, which can be inflammatory, infiltrative, or compressive. Papilledema term is used when it's bilateral optic disc edema, and it is caused because of raised intracranial pressure. Pseudo papilledema, the term itself is self-explanatory. Pseudo, that means it's false. Papilledema, it gives a look of optic disc edema, but actually there is no true edema of optic nerve fiber layer. So a 42-year-old man presented to our hospital with diminution of near vision. So we just prescribed him presbyopic glasses, and while doing his routine fundus examination, we appreciated that the disc was swollen and raised in bilaterally in both his eyes. So we took a detailed history. There was no history of headache, no doubling of vision, no history of any transient visual losses, and patient was even non-hypertensive. So we conducted a detailed ophthalmological examination. His best corrected distance visual acuity was 6/6 in both eyes, and because the nerve was affected, so we checked the ocular movements nicely. They were painless, they were full and free. Pupillary reactions were normal. His anterior segment in both the eye was normal. To assess the function of the optic nerve, the color vision was tested by Sciarra chart. It was normal. Intraocular pressure was normal. His blood pressure also came out normal, 110/80. So hypertension was as such ruled out. His fundus examination, we do not have the fundus camera with us, so we asked the patient to get it done from outside. These are the pictures taken up from his fundus pictures. So 2D images are not showing exactly, but the disc were swollen, they were raised, and the margins were not exactly blurred, but crenated kind of image they were giving. Spontaneous venous pulsations were not appreciated in that patient. So we advised, we were thinking in terms of pseudotumor cerebri. So we advised MRI brain with orbit to that patient. There was no space occupying lesion found in MRI, and overall the optic nerve didn't show any restricted diffusion, no abnormal enhancement was seen. However, some patchy areas of altered signals were seen in temporal aspect of both the optic nerves, right more than left. So then, because the MRI came out normal, we still referred patient for the neurologist opinion, and then we started having other differentials into the picture. We thought maybe some, pseudo disc edema is there. So we thought in terms of optic disc drusen. So we conducted a fundus autofluorescence test, which came out negative. There was no autofluorescent disc drusens were seen. OCT optic nerve head was also done. The OCT optic nerve head did show that cup was obliterated, but the RNFL thickness overall in all the quadrants in both the eyes came out normal. The visual field test revealed no enlargement of blind spot, no hemianopia or no neurological defect, no altitudinal defects were seen. So the neurologist suspected in terms of neuromyelitis, optica syndrome kind of optic neuritis they were suspecting. So they wanted to assess the optic nerve visual function. So they advised VEP and anti-NMO and anti-MOG antibodies, which eventually both the antibodies came out negative. And VEP also showed normal PE100 latency with well-formed and reproducible waveforms in both the eyes. Now, there was no obvious symptoms and signs of raised intracranial pressure. All the tests were coming out normal. So we were also confused. So we thought maybe, we just kept the patient on regular follow-ups. So, in case of true edema, why I'm presenting this case is basically in cases of true disc edema, before labeling any patient as pseudopapilledema, you have to do like extensive workup of such patients, because missing a case of true edema can, delay in treatment can really lead to serious neurological complications. The differentials I'm going to discuss will be optic disc drusen's, congenital dysanomalies, and pseudotumor cerebri. Pseudotumor cerebri or idiopathic intracranial hypertension is basically a disorder of elevated, in this, the disc edema is because of the elevated cerebrospinal fluid pressure, and there is no known cause for it as such. It's more common in childbearing obese women. Patient presents with headache, transient visual obscurations, and visual losses. Signs will include papilledema with sensory visual function loss and diplopia. Optic disc drusen's are extracellular deposits consisting of calcium, hyaline, and other proteins located posterior to Bruch's membrane. They'll give, we can differentiate optic disc drusen by simply doing an ultrasound B scan also, because they are calcific deposits and they are autofluorescent. Thank you.
Those costly investigation first.
Sorry, I
your
can't hear
case,
you, sir.
So many investigation done.
Yes, sir.
Can you, in your practice, is it not possible in all the cases? Can you cut short the investigation in such in your case, like in your case? Can we cut short our investigation?
Cut short the
Yes,
investigation.
because
Ultrasound.
lots of investigation done, the opinion from neurologists.
Yes, sir. Yes,
and
sir.
frankly speaking, to a neurologist, that fees are all around
I think so.
1,000.
Yes, sir. So I think so 2 investigations would have helped, like ultrasound B scan, वो optic disc drusen's को rule out कर देता अगर मतलब वो calcified था तो होता. Second is FFA, I think would have been a better option. We advised him FFA only, but he ended up getting the fundus autofluorescent, because FFA में अगर leakage होता, disc leakage होता, तो वो true edema reveal हो जाता, और अगर वो absent होता तो true disc edema anyways उससे हम रूल आउट कर देते हैं, और उसके फंडस फ्री फोटोग्राफ में हमें ऑप्टिक डिस्क drusen भी रूल आउट होते हैं. आई थिंक दोस टू इन्वेस्टिगेशन वुड हैव हेल्प्ड अस बेटर.
Those are basically theoretical. In practical, we can just examine the blood pressure, the physical things, and the optic disc. We can evaluate even every 15 days, every 1 month.
Okay.
If it is enlarged, then we can observe, and 90 days, 78, even 60 days after are most of the time enough.
All right.
If that vitreous, everything is normal. If no cells in the vitreous, nothing, and pupillary reflex, and in each and every cert, all certs are color vision certs are available. It is very, very important. But color vision, if you can do, so most of the time in papilledema, of course, it N only,
Yes,
the
sir.
N stage, but those are the basic steps before sending patient for a costly investigation.
Okay, sir.
Okay.
Thank you, sir.
Yeah.
Thank you, sir. Thank you, sir.
This is a really actually.
Good afternoon, everyone. This is Dr. Kiran Sarodev from JR3 from Kasturba Hospital, Sevagram. I hereby going to present a case of neuromyelitis optica. So my patient, 27 years old male, known case of multiple sclerosis, presented with chief complaints of diminution of vision in right eye since 8 days. That was sudden in onset and progressive in nature. There was history of weakness in all 4 limbs with history of difficulty in urination. The clinical examination of the right eye was The visual acuity of the right eye was a counting finger 2 meter with projection of rays accurate in all quadrants. Extraocular movements were noted that was full and free in all direction of gazes. Pupil was 3 to 4 millimeter with a relative afferent pupillary defect. The fundus of the patient was dilated and the findings were disc was normal in size, shape and color, margins were ill-defined, CD ratio was 0.3:1, arteriovenous ratio was 2:3 with background normal and foveal reflex was present. The MRI of the patient was requested with MRI spine showed poorly delineated longitudinal extensive altered signal intensity areas extending from spinomedullary junction to cervical spinal cord up to C5 vertebral level with mild cord edema, mostly of inflammatory etiology. MRI brain and orbit of the patient showed few punctate signal areas in bilateral periventricular white matter and bilateral centrum semival, likely suggestive of demyelination. Right optic nerve appears mildly tortuous and bulky as compared to left optic nerve, predominantly in retrobulbar and mid-orbital region. The VP of the patient was done to assess the optic nerve function, which showed P100 latency is markedly prolonged with reduced P100 amplitude in right eye as compared to left eye. So patient was diagnosed as neuromyelitis optica and treated according to ONTT trial. The patient was treated with injection methylprednisolone 1 gram intravenously for 3 days. The best corrected visual acuity of the right eye was after 3 days on Snellen's chart was 6 by 60 with projection of rays accurate in all quadrants. Patient was discharged with oral prednisolone for 11 days and reviewed. Neuromyelitis optica spectrum disorder is an uncommon antibody-mediated disease of the central nervous system. The aquaporin 4 water channel was identified as an antigenic target for the disease through detection of the aquaporin 4 antibodies. More recently, another antigenic target, myelin oligodendrocyte glycoprotein, has been identified in patients with neuromyelitis optica spectrum disorder. For myelin oligodendrocyte glycoprotein antibody disease, the female to male ratio is approximately close to 1:1 in contrast to aquaporin 4 antibodies, which was 9:1. The prevalence of neuromyelitis optica spectrum disorder is approximately 0.3 to 4:4 per 1 lakh people. It is seen more commonly in females and younger patients. Our patient belonged to same age group but was male. The feature of neuromyelitis optica can present in patients with multiple sclerosis at the same time, or it can be separated by many years. So the conclusion of my study was optic neuritis treatment trial has changed the practice patterns of ophthalmologists and neurologists worldwide and improved the care of many patients with optic neuritis. Thank you.
Thank you. Just remember that the ONTT was for multiple sclerosis and optic neuritis in association with that. And while we are using the same treatment when we are talking about NMOSD and MOG, the ONTT actually did not, at that time when the ONTT was done, we did not know about the existence of MOG and NMO. So yes, we need to identify NMO MOG more aggressively because of their poorer outcomes, as a previous study has also shown. So thank you. I think that was a very, very nice case, and I'm showing the importance also of the MRI spine that can help us in picking up patients with NMOSD. Thank you. Next.
How can I change the slides? Can you reset the timer? How can I change the slides?
Everybody, the subsequent speakers, to please load it at the presentation. We don't want to waste any time. Please go ahead.
Timer change. Color vision testing is online smartphone app an alternative to traditional Ishihara handbook. The assessment of chromatic discrimination ability and diagnosis of any perceptual deficiency is color vision testing. It's a part of functional assessment of the visual system by ophthalmologists. With technological advancements, digital version of commonly used Ishihara is now available on online platform. Cone photoreceptors in retina help in color perception. 3 types of photoreceptors corresponding to 3 primary colors result in trichromacy: red, blue, and green. Not all people possess trichromacy, and some are partially or completely colorblind. The most common form of color deficiency is red-green deficiency: protanopia, protanomaly, deuteranopia, or deuteramelia. Color deficiency may be caused by acquired diseases like cataract, glaucoma, trauma, or medication, or aging. The Ishihara test is a color perception test for red-green deficiency, which is the first successful vision test called pseudo isochromatic plates. There are several test designs: introductory plate having 12, which is visible for all; transformation plate, which color vision deficient cannot see the differentiate and only normal people can see; vanishing plates, only people with normal color vision can recognize these figures; hidden digit plates, only the people with color vision defect can recognize these figures; diagnostic or classification plates determine the type and severity of color vision defect; tracing or pathway plates, where the subject is traces a visible line across the plate. With advancement in smartphone technology and medical software applications, physicians are increasingly incorporating it into their daily life. Smartphone applications has advantages like it is affordable, accessible, prevent delay in patient care, solve the problem of shifting colorimetric values with aging of the physical color plates, interprets its result by differentiating between color deficient and normal person. However, it is unable to classify the type of the color deficiency. In our study, it was a random observational study. We took 120 participants of age 18 to 30 years visiting our outpatient department. An informed consent was taken, visual acuities as distant and near were assessed, ophthalmoscopy performed to rule out any ocular pathology. People with ocular pathology or visual acuities worse than 6 by 6 were excluded. Participants with specs or contact lens were asked to wear those. Room illumination and standard distance were maintained. 2 tests were conducted, first right and then left eye, and both handbook and digital version were used randomly. 9 error or more in the Ishihara were categorized as red-green deficiency and failed the test. We found the result, 52.5%, we took 52.5% male and 47.5% female. 4 out of 63 men were color deficient. The sensitivity and specificity of our digital version were found to be 100%, as Ishihara was the standard for comparison. In various responses for 4 men who failed screening test on digital version were recorded, were compared with the handbook. In our study, sensitivity and specificity of digital version of Ishihara as compared to the smartphone application is 100% and 100% respectively. Combined sensitivity of transformation and vanishing plates in the digital version of Ishihara makes it an efficient screening tool due to red-green color vision deficiencies. In several studies, like in Hoffman and Mazzoni study, they found traditional Ishihara test compared to computer-based screening system. Both were efficient, even though spectral emission of the monitor and reflected daylight with traditional Ishihara plates, there was correctly distinguished subjects with color deficiencies from those without any. Rodriguez found 20% of the normal trachomers failed the test, suggesting the limitations in its application. In accordance with Hoffman and Menozzi, the present study confirmed that the digital method was able to distinguish between participants with and without color deficiencies. Coming to conclusion, the digital smartphone application version of Ishihara is a possible alternative to screening for color deficiency in unavailability of the traditional Ishihara handbook, and also provide a convenient self-screening alternative to in-office assessments, or when the test is required to be done by untrained professionals. However, test has the limitation as it was not able to accurately detect the severity of the deficiency. In case of participants who are possibly identified as having color deficiency, a thorough in-office assessment is required to be carried out by appropriately educated professional using the traditional Ishihara handbook in the standardized conditions. Thank you.
Are you prefer direct ophthalmoscopy first or indirect ophthalmoscopy first or color vision earlier? In your practice, suppose one patient in front of you, are you prefer to do ophthalmoscopy first or color vision first?
So we'll do color vision testing first, then we go for ophthalmoscopy.
What was the color vision app that you had used? You had not, I think, mentioned it in that.
So we used random apps. There was no specific app used. It was a Ishihara testing app named.
It was not the same app you'd used in all
So
patients?
we used the same app, but it was Ishihara testing app which was available online. It is shown here.
So Ishihara, unfortunately, is not there to make the app, so somebody would have. But anyway, sure. Just remember, always, the testing modality must always be mentioned in your presentation or wherever you write, okay?
Yes.
Because otherwise, how will we, if somebody wants to recheck the values of your study, how would be? The only downside of your study I can see is that the number of patients who tested abnormally on the Ishihara were only 4.
Yeah.
So that's a very small number to actually test the digital app on its inability to pick up color vision deficiency. But anyway, it's a very nice and very important thing. Thank you. I think we'll go on to the next. Thank you very much. Dr. Aditya is there. So we can thank Dr. Aditya who will help us to get this session closed on time. Last. Yes, as soon as there's. Is there Dr. Shadma? We are grateful. So thank you. We have both of them are not there. So we are. Thank you. We end the session. Thank you very much, everybody. Excellent presentations. It's always very difficult, and I'm grateful and glad that neuro ophthalmology is picking up. Young people are interested in doing research in this. And truly speaking, neuro ophthalmology is something that is very exciting. And frankly, its time has come. This is one of the subspecialties that is now really making its being felt in ophthalmology circles. So thank you, everybody, and I'll hand over the dais to the next.
I request everyone to become a member of our society because it is a very, very new society. So we want everyone's support. So lots of, still now that other people are, it is actually very in baby form. That neuro-ophthalmology thing is very baby form. Few people are working, so we want everyone's support.
Yes. Thank you. I think no, we just.